Hello, Dr. Willey. Hi. I'm so excited to see you after 20 years.
It's really been 20 years. It's so funny. I actually, hang on one second.
Yeah.
I just pulled this out to show somebody recently.
I'm glad you have that because I was going to show it, but it's in Portland and I'm in New Mexico right now.
You want me to have it out?
Well, you can show it when we start. 20 years ago. Actually, we started that in 1995.
Isn't that something? And
yeah.
I hear that you're friends with my trainer.
Who?
Stacy Mann.
Oh, how funny is that? That's awesome. That's awesome. Very cool. Yeah.
And I didn't realize how famous you are among all the trainers.
I wouldn't say that, but it's it's funny because, well, it's not funny when we started this in '95 and Amy was doing her master's thesis at GW, and we haven't spoken since like 2000. I don't know what happened to her, but throughout the years, all the paths cross. And then I met Dr. Harness and he told me that you guys were close. And I'm like, oh my God, this is so crazy.
I think you're frozen.
Not sure what happened.
You froze.
Yeah, it like went away. So I'll edit the presentation afterwards. So hopefully Jay can figure out how to get on here and he's got the right link. So what you been doing for 20 years?
Well, let's see. I was at Georgetown for 17 years and then I came out here about 9 months ago, half of which has been spent dealing with the pandemic.
Yeah.
It's just It's crazy.
That's probably another good thing to talk about too. And we've got a couple minutes before we start, but just to get your guys' perspective on cancer patients and the pandemic. In fact, I wanted to send my mom to talk to you, but what she needs is an oncologist. I'm not going to mention names, but we don't like the care she's getting. And I was talking to Jay, she's got stage 4 widespread breast cancer now. So it was her second diagnosis when we started working together on essential exercises. And she was just diagnosed about 2 years ago. So maybe I'll reach out to you, see if you have any recommendations, because she's still in Maryland and she's out there alone. I was supposed to fly out there yesterday and I'm just too afraid to bring her whatever latches onto me. And so yeah, I'm very curious to get you guys' perspective on this. Okay, I see Jay just popped up. Where is that handsome guy?
Hey.
There you are.
You no black eye or anything.
I know, looking good.
You look good.
Yeah. Can you hear me okay? I've got
yeah, everything's good and we are right on track. So it's being recorded live and I told Shawna, and I think I sent you the thing, I want to just talk to you kind of candidly about, everything from, lumpectomy, mastectomy into breast reconstruction. Obviously Jay and I have been talking more often since Shawna and I have not seen each other for 20 years. So I want to start off with introductions to you guys, and I am going to have to cheat because you guys have such an accomplished bio here. But for everybody else who's signing on, welcome. In the top left, you have Dr. Shawna Willey, and I am reading this straight from the script. So, but I have to say, I met Dr. Willey 25 years ago. I can't even believe, like, almost half my life ago. My mom had been diagnosed for the second time with breast cancer, and you guys have all, that was the inspiration for everything. Now you can hold up the book, Dr. Willey. And she wrote the foreword. We had Peggy Fleming write the whatever it was.
She wrote the foreword and I wrote the introduction.
Okay, you wrote the intro. I got it backwards. So we have not seen each other since then. I left DC and moved out west in 1999. So this is really, really exciting. And then Dr. Harness is our medical director, and lo and behold, they both work together and are very close colleagues. So let me give you Dr. Willey's bio here. She was recently named the Peterson Chair of Breast Cancer Research at the Inova Shar Cancer Institute. Am I pronouncing that right?
That's correct.
In Fairfax, Virginia. And she's a professor of surgery at Georgetown University Medical Center, where prior to coming to Inova, she served as the chief of the Department of Surgery at MedStar, Georgetown University Hospital. And let me tell you, you guys need to just go to the advisory board panel on our website to see the credentials for these two amazing doctors, because the list goes on and on. But when I met you, you were at GW, and you were chief of breast surgery at GW, correct?
Yes.
Okay. Anything else super important right now that I'm not hitting on? Because you have such an accomplished career, and it's just amazing seeing what you've done over the last couple of years. Am I missing anything that you want to mention?
Well,
right now?
I'm going to mention that the reason Jay and I know each other so well is because we both are past presidents of the American Society of Breast Surgeons.
Yes.
And we met in that venue. We both, and he's also a past president of Breast Surgery International. So Jay was the president right before me of the American Society of Breast Surgeons. So I would say we got to be very good friends during that period. And we have collaborated. We're co-author or co-editors of a textbook on nipple-sparing mastectomy. So those are kind of our connection to each other. I guess these books are our connections, huh?
Yeah, and now I don't have to say that about Jay. I can just go on to all the other stuff. So Jay has been working with CETI for, I guess, the last 2 years, and we've been collaborating with a number of other amazing professionals in the industry. We've just recently added Catherine Schmitz and Karen Wonders. Katie Schmitz and Karen are both researchers in the area of cancer and exercise, both extremely well known. Katie, the most recent president of ACSM, and Karen Wonders is with Maple Tree Cancer Alliance. I believe I'm saying that right, because they just merged with Sunflower Wellness. So we've got a really great group we've been working with. But Jay is, I know Shawna just said this, the past president of the American Society of Breast Surgeons and Breast Surgery International, and a full-time breast surgeon at St. Joseph Hospital Center for Cancer Prevention and Treatment. But I think you're not full-time anymore, right? You're part-time now?
Well, I'm in my 46th year of practice, guys.
Okay.
I'm starting to wind down a little bit, but
Yeah.
things are still stable, okay? That's the only thing.
Yes. And you've been practicing, yeah, it says for 40 years, so this must be a little bit older, but you specialize in breast surgery and surgical oncology. And same with you, Dr. Willey, correct?
That's correct.
Okay, so you guys, they're listed on our advisory board. We have a brand new face to the website, which you'll see next time you click on thecancerspecialist.com. So, Dr. Willey just brought something up, Dr. Harness. I've got to get formal with you guys now. Or can I just call you Shawna and Jay?
You can.
Okay, thank you. All right, so Jay, Shawna had mentioned, life with the pandemic, and being cancer doctors. I think one of the questions all of the cancer exercise specialists have is, what is your recommendation? And I know, having my mom who's afraid to walk out of the house, most cancer patients are not going to gyms. Would you tell them to? Or would you tell them, while they're in active treatment, while their immune system's compromised, would you suggest that they stay home, that they exercise in the comfort of their own home, or work one-on-one with a trainer? What would your advice be? And you can both
It's obvious. We've got to do exactly what's been recommended, which is social distancing, wearing masks, staying out of large groups of people. All the things that the president is not advocating is what I'm sure Shawna and I will be advocating.
I'm right there with you.
As much exercise as people can do at home. You can get TRX straps up in the garage. I mean, there's all sorts of stuff that you can do at home. Range of motion, things that can be done. Keep moving is really the bottom line out of all this, you bet.
Absolutely. So we're teaching people how to do virtual assessments. I remember going into GW 20 some odd years ago and having a cheat sheet of how to do goniometric shoulder measurements. We're teaching our cancer exercise specialists how to do this virtually. And whether it be, you know, using a goniometer, we can actually hold it up to the screen, or just eyeballing it, we're able to come up with a baseline of information to start with the client to take them from point A to point F, because I've got about 5 or 6 different components that go into putting the exercise program together.
But if I could say, Andrea, I think this is something that has is a bit of a gap that's happened during the pandemic, because women are heeding the advice to not go out. And I personally find that patients benefit so much, no matter what their operation was, from going in and doing something physical, having that assessment, and then having an exercise program. And I sadly see women who are forgoing that right now because they're so afraid of having contact with people, and they don't understand that slowly but surely we're learning how to help people with this from afar. And we're able to do Zoom conferences, and a trainer or a therapist can assess someone at least visually and give advice. So I'm really sad when I hear somebody say, no, I'm not going anywhere, and I'm not going to do any of the Zoom calls, because I really think that's still beneficial to them.
Absolutely. Totally. And, you know, hey, come on, guys. Everybody's got a smartphone virtually. Almost everybody's got a laptop or some sort of computer with a camera in it. But one of the things that we worry about is atrophying to death. And if we're just sitting home and not moving, particularly post-surgery, I mean, the amount of muscle atrophy that we get and all these other negative things is significant.
Well, so, and it helps your immune system too. I mean, exercise and proper amount of sleep, stress management, and of course, you know, the stressors are even higher now. So exercise can certainly help with that. And so hearing you both advocate for it, you know, one of the issues that arises quite often. So Shawna, having started this, you know, 25 years ago, here we are from the time I met you to the time I met Jay, and not much has changed in the sense that there is this break in the system somewhere where maybe the doctors, maybe the surgeons do tell their patients to exercise, but without enough detail. Maybe they don't. Maybe the patients forget. Maybe they don't know who to go to. So what do you think the best way for a cancer exercise specialist to integrate or to become that next step? Obviously, you know, we're connected all through CETI, but you know, when we're talking to the specialists and say, all right, here's what you do. You're going to go out, you're going to call this doctor, you're going to call that doctor, and you're going to introduce yourself. You probably get bombarded by people who want to talk to you all the time. What is it that would make you refer somebody to a specialist? Like, what kind of credentials, or are there any questions you would even ask?
Well, we should be assessing people as part of the initial history and physical about what their exercise level is. Shawna, I think I've shared with you, but I'm now a proud member of the American College of Sports Medicine. I'm actually working with the leadership at ACSM to establish a standard with the National Accreditation Program for Breast Centers, an exercise standard. The number of clinical trials that have been done over the last 10, 15 years, the amount of evidence-based evidence that we've got, if that was a surgical procedure, we would have already implemented it 10 years ago. If it was a new chemotherapy, we would have implemented that 8 years ago. Right. So what is really needed is an initial assessment by cancer physicians, by whoever, members of the multidisciplinary team, and then getting them into the hands either through a Department of Physical Therapy or whatever it is, to then lay out the program. And where I think the people that you've trained, Andy, will be really handy is after they get out of the medical center, and it's the follow-up and out into the exercise world, which is gigantic world in the US and worldwide.
And we're trying, you know, for you guys who are watching this, we are working collaboratively with Karen Wonders and Reagan Fedrick, who have a clinical-based practice throughout the country. And I think they're international as well, so that we can create this perfect flow from the doctors to the inpatient or the clinical setting, and then to the cancer exercise specialists, who can be in a clinical setting also, but out in the gyms or studios, whatever fitness looks like in the future.
Yeah, it's got to be a continuum, and you broke it down beautifully. Part of it is clinical, vis-a-vis right around the medical center time. Shawna, I'm sure you'll agree, most patients, once they get done with everything, have post-traumatic stress disorder. The last thing they want to do is go anywhere near a medical center.
They don't. And I think that's why a lot of medical-based programs fail. I remember talking with Suburban Hospital 20 some odd years ago about incorporating it when they were like merging with Johns Hopkins or what have you. And it's just, people don't want to go back down the hall from where they had radiation or chemotherapy.
Right. So we want this continuum then into the fitness world. And I think the people that I've come in contact now with out in the fitness world, they're really interested, really interested. And it's obviously got to be combined with heart healthy, other things like getting diet control, meditation. I mean, all these things, it's really sort of a big picture. Shawna, what are your thoughts?
Well, I'm thinking about my new location when I've been here about 9 months now, and we have this phenomenal program called Life with Cancer that incorporates all of these kinds of things in a different setting, a different physical setting, and it does kind of help with that continuum. Yes. I think part of it, as you say, Jay, is education, because patients always say, well, what can I do so that I don't get cancer again? And exercise is one of the only proven things that they can do to decrease their risk of getting a recurrence or having another episode of cancer. So we have to make the patients believe that, first of all, and then we have to make it easy for them. And Andrea, you asked, what can you do? It all has to be easy for us too, so that the patients are making those contacts. It's kind of effortless, and maybe it's a graduated process for them. One of the things that was making me smile is I'm currently taking a Tai Chi class. And because the gyms are closed, we can't do Tai Chi in the gyms, but we're going outside and we're doing Tai Chi. And my instructor actually comes to the infusion center, and she does Tai Chi with people who are actively getting infusions right now. And it's just phenomenal.
Yeah, outstanding. That's spectacular, Shawna. And you know, you need to be writing that up and letting the world know what you guys are doing. I mean, that's just spectacular.
Yeah.
And that's where all of us working together, I think, you know, this journey we've been on this year, and pulling all these people in who are leaders in the industry, both from research, I shouldn't say both, including research, medical, fitness, and everywhere in between. Well, I'm going to get to some nitty-gritty questions with you. You know, we spent a lot of time talking about breast cancer, even though the coursework covers 27 types of very common cancers. But with breast reconstruction and all of the options for, you know, lumpectomy, mastectomy, first off, in your opinion, are you doing many modified or simpler total mastectomies anymore, or are you going more towards a lumpectomy? And or what are the parameters? What makes you do one versus the other?
Shawna, go ahead.
Well, first of all, I'm going to say to you that I've heard about your coursework from some of the trainers that I work with for all the disease sites, and they say it's very difficult.
It is.
This is not a slam dunk.
On that note, as it should be, right? Somebody, and I don't think they were being attacking, but it was on LinkedIn, and they said, they were talking to somebody else, and they said, that personal trainer, Andrea Leonard, who works with cancer patients. And I wrote back, I'm like, I'm not a personal trainer. I'm an educator who trains cancer patients. And they were saying that people should have an exercise as medicine cert. And I said, they're not going to get what they need for working with cancer patients from 10 pages, even if it's from Harvard or Purdue or whatever, there's not enough information in any one course other than, you know, something that is specializing in entirely cancer. So we have about 500 pages, and it is hard. And they have to retest every 2 years so that you as doctors know that if somebody says they're CETI certified, that they have the highest level of training, you know, in the fitness industry, and that they are up to date on their information. So I'm glad you brought that up.
Well, I literally just heard that last night, so from one of the trainers. So going back to your question, we still do a lot of mastectomies, and I would say in my hands, about 50% of the patients that I'm operating on for breast cancer or for prophylactic surgery are getting mastectomies. I do want to debunk a myth, and I hear this even among healthcare providers, about the patient had a radical mastectomy. It is incredibly uncommon to have any patient currently have a radical mastectomy. There's very rare indications for it. So I really try to get people away from that terminology because that's really the old style mastectomy that is so rarely done anymore. But that being said, we're doing lots of mastectomies. We're doing a lot of reconstruction. I'm just working on a paper that shows that about 70% of the patients at MedStar, my old location, are having reconstructions. So reconstructions bring with them a different set of issues for these patients. Mm-hmm. And I think that all needs to be addressed, because whether they're having an implant put in or whether they're having their own tissue moved around, they have different needs that they need as far as rehabilitation and exercises. And then, of course, the lumpectomies and sentinel node biopsies. We certainly are doing fewer and fewer axillary lymph node dissections now, but they do still occur.
So a couple questions.
Andy, let me cut in for a second. The other day,
I'm just going to make a note so I don't forget.
Yeah, the other day I was listening in on one of your lectures and talks, and you were talking about breast cancer, and one of the first things you jumped to was radical mastectomy or modified radical mastectomy. I'm with Shawna. I want to get that out of our nomenclature.
You don't even call it modified radical anymore?
No. I mean, we know what it means, but there's so few of those that we do anymore. Typically, we're talking about skin-sparing mastectomies with reconstruction, or we can be talking about a total mastectomy without even reconstruction. I operate many older women where I'm at up in Bishop, California. I've got women in their late 70s, 80s. The eldest I've done recently was 93 years old. Wow. She didn't care about reconstruction, so we're trying to get the redundant skin down flat in the chest wall so it's easier to wear a bra with a prosthesis, etc. So the two terms that I would use is talk about skin-sparing mastectomy or nipple-sparing mastectomy combined with some level of lymph node sampling and perhaps surgery, okay? But Shawna is absolutely spot on with that.
Yeah, and in the handbook, the reason all of those are in there is because they're still out there, you know, in the world, on the internet. So it's basically just explaining it, not so much saying that they're being done, but it's great input from you, as is what you mentioned about the implants now being placed above the pectoral muscle as opposed to below. But real quick, before we get into that, just a quick question about sentinel node biopsies. So we used to say that there was no chance of getting lymphedema after a sentinel node biopsy, where now there's, you know, a small percent, 6 to 8%. Is there any chance, this is a little side note, that you will remove a sentinel node, it comes out negative, and somehow the cancer is still in the lymphatic system, that it bypassed the sentinel node?
Sure. Shawna, you want to comment? I've got a comment or two. Go ahead, Shawna. Please.
That risk, based on lots of studies, is certainly exists. It's probably no greater than 2 to 4%,
okay.
But probably less than that in my experience. And the only way that you would know that at this point is if somebody had an axillary recurrence in a short period of time after having a sentinel node biopsy, or there are times where people can develop metastatic disease and their lymph nodes were negative. But it's very rare. I have seen, I've done 1,500 sentinel node biopsies, and I've had about 4 local recurrences in the axilla. So it's very uncommon.
And so what would it make you choose to go in? Let's say, so the sentinel node comes back positive, and then you take a larger cluster of nodes for sampling?
Well, not always.
It depends. Go ahead, Shawna, go ahead.
And that's why I say that sentinel node, or we're doing fewer and fewer axillary lymph node dissections because we are using more and more radiation.
Mm-hmm.
And there's really a trend now. There's some major pivotal studies that have been published. One is called Z11. One is called Amoros, that show that taking out more lymph nodes doesn't necessarily decrease the local recurrence and doesn't necessarily obviate the need for radiation. However, you do have to fit the criteria of those studies.
Right, and I know that there's so many variables.
Yeah, Andrea, the difficulty in making gigantic statements is that breast cancer is fundamentally a heterogeneous group of diseases. Mm-hmm. And we're really trying to personalize to each case. And we're doing less and less in the axilla. The other thing, can you end up having a sentinel node that's negative and yet miss a positive node slightly upstream or whatever? The answer is absolutely. So I always make the point of carefully palpating the axilla, because if a lymph node is stuffed full of cancer, then a radioisotope or whatever you're using can't even get into it. Mm-hmm. So you're combining this with the pre-op physical exam, you're combining it with what you find in the operating room, plus palpation, et cetera. Mm-hmm. Now, I want to make a really important generic point, and I think Shawna will agree with me. So often, patients think, I just want the biggest operation you can have, take out all the lymph nodes you want, I'm going to be fine when you do that. Forgetting completely the fact that as soon as a cancer is invasive through the walls of the ducts or the lobules, we have to treat the whole body. Yeah. Because it's not the cancer cells in the breast that are going to kill somebody. It's the cancer cells going elsewhere. So that's another reason why we've put less and less emphasis on the axilla, because we are treating the whole body with virtually everybody, okay?
Well, and people don't understand. I mean, my mom's 82, has widespread breast cancer. She's, and she constantly asks me things like, you know, why is this cancer here or whatever? And I explain to her, it's systemic, it's breast cancer, it's still being treated like breast cancer. And I think it's very hard for the lay person to really understand that. So obviously, having a doctor, surgeon, oncologist who takes the time to discuss it, which I'm sure is a big part of your practice with the patient and your bedside manner. And that's why you two are where you're at in your profession, and you know, you've contributed so much to it.
I'd also like to say, I'm going to take that even further, that sometimes patients think that a mastectomy is a better operation than a lumpectomy, mm-hmm. because it's a bigger operation and you're taking more breast tissue. And there's always this statement that, well, if I have a mastectomy, then the cancer can't come back. Isn't that right? And the answer is that is not correct. And a bigger operation doesn't necessarily mean that you're going to have a better outcome. And that's a big myth that we fight on a daily basis.
Absolutely.
Yeah. Well, I think there's some current evidence that's showing when they're comparing a lumpectomy with radiation to a mastectomy that in many cases the first choice is better than the second. So I'm sure there'll always be controversy.
Yep, you're absolutely right.
I just got a little chat message said, Dr. J, I appreciate the heterogeneity of the disease and personalized medicine. Thank you, whoever just sent that comment in.
Yeah, and I'll go through the comments later. If I find that if I look at the comments, I somehow or another lose the screen.
Well, whoever it was, I think it's from Australia.
Okay. Yes. So, Jay, let's talk now about the placement above or below the pectoral muscle of the implant, the whole process with the expander, because there's a lot of questions. Let's first talk about the implants, and then I want to talk about your precautions while somebody has an expander in place versus, you know, when you replace it with the implants.
Well, there's a couple of approaches. One is a two-step approach, where you're putting an expander in first and then expanding out to the size you want, letting a capsule form around it, take the expander out and putting a permanent implant. At Shawna's institution, or former institution, was one of the big leaders in the country and one and done.
Okay.
Using special technology called ICG in the operating room to look at the blood flow in the flaps. And this was particularly useful, and Shawna should be commenting, not me.
You can comment.
Yeah,
I want to hear what Jay says, though.
but particularly useful in somebody who can do one and done and who did not want to be larger cup size wise. I mean, if somebody was a B cup and they wanted to come out the door as a D cup, no, you're going to need an expander and do that slowly over time, etc.
Okay.
The other hottest subject going on over the last 5 years or more has been prepectoral, less dissection, less disruption of the muscle, and particularly if we leave the flaps thicker, which is one of the big things I've advocated for.
Now, can you explain a flap to the people watching? Because we speak about free flaps and tram flaps, but when you're referring to the breast, you're talking about the 2 flaps of skin that are left?
Yes, it's the envelope.
Mm-hmm.
Think of the breast as it has a skin envelope. Underneath that skin envelope is a layer of fat that varies in thickness depending on the whole body fat content the patient has. And then inside that envelope, if you will, is the breast. Okay. All right. And so we've been emphasizing, at least I have, and I think Shawna agrees, that we want to try and preserve that blood supply, keep that flap as thick as we can, but obviously not leave any breast tissue behind or have an edge where the cancer is growing into it, thinning it out, etc. And then there are many times where we actually reduce the size now of the skin envelope as we do our oncoplastic approach to patients. That's so all this jargon, people need to be working with a multidisciplinary team. A multidisciplinary breast surgeons, pathologists, radiologists, plastic surgeons, and others, so they can get through all the jargon that we're talking about and end up personalizing the care to that individual set of circumstances.
Right.
Shawna, please.
Well, I agree with all of that. I always tell the patients, I've spent 30 years learning all of this, so I don't expect them to learn it in a crash course at the time of their diagnosis.
Yeah.
So you do have to rely somewhat on the professionals that you've chosen to work with, and the professionals you've chosen to work with need to work together to provide that personalized care to you. I think the another situation that I want to mention is that when we do nipple sparing mastectomy, we're saving all of the skin and the nipple, and it's easier to reproduce your body's form that way, because the only scars, if we can do it because of the size of breast and location of tumor and all of that, are scars that are right at the bra line. Yeah. And so when you look in a mirror, you might not even see a scar. There are times when we do not think it's safe to save the nipple, and that is very individualized. And if you're in a situation where the surgeon says, "I don't think you can save your nipple," just ask why. I mean, there needs to be a reason for it. But in that situation, then it might be more likely that you would have an expander because you have had skin removed, and depending on what size you want to be, in that situation, you get to choose. And so every once in a while, you get some say about things. And so many patients who are going through a cancer diagnosis feel that they've had all their options taken away from them. So it's kind of nice to have control once in a while.
That's kind of one of my taglines is cancer strips you of everything and you feel that you have no control. So we help people to take control of their bodies again. Are you only using those these days with earlier stage cancers, or does that depend, like you said, on the size of the tumor, where it's located?
You know, nipple sparing mastectomy, I started doing these almost, I guess, 2 decades ago now. And we've just increased the indications for them. And so it used to be that it was very early stage disease. But now we know that we can do it in later stage disease. We can do it in people who are getting preoperative chemotherapy. We can do it in people who are going to get radiation. There are very specific situations where we would not recommend saving the nipple. People who have an inflammatory carcinoma, which is a fairly rare or fairly uncommon, at least, type of a specific type of cancer, we would not recommend that. Certainly if you have a disease called Paget's disease that involves the nipple, we would not recommend saving the nipple in that situation. And of course, if the tumor is very close to the skin or very close to the nipple where the skin might be involved, then we would not recommend saving the skin in that situation. But those really have been decreasing contraindications or reasons to avoid doing a nipple-sparing mastectomy. And we've really been expanding the indications over the course of the last 2 decades.
And in that case, would you do an areolar incision as opposed to beneath the breast? And then you would just remove the tissue through the areola?
Yes.
Where the areola was?
If we're taking the nipple, we would do either a circular or an elliptical incision. Again, as Jay was saying, sometimes we have to reduce the amount of skin that somebody has. Somebody is very large breasted. We need to reduce the size of the skin envelope because implants only come in certain sizes. So you kind of have to tailor it.
Right. And so when you were touching, and I'd love to hear both your opinions on this, you were touching on the above or below the pectoral muscle. So going back to when they're placed beneath the pectoral muscle, you have to cut through the pectoral muscle to get through it, and that's why there's so much pain. How does that work? What's that process?
Well, typically it's cutting the origin of the muscle completely. Then you've got a gap because you've got the muscle draped over the tissue expander or implant, and then filling that gap with various elements or whatever. So, Shawna, what's going on back east as far as prepectoral now and ADM and all of that sort of business? Is it hot?
I don't know anybody here who is doing retropectoral implants as a primary reconstruction. There are times you need to do it if somebody's had radiation, they have poor skin quality. You might choose to do it. But that's another thing, Andrea, that came along in the early 2000s, which is something called acellular dermal matrix. And it's as it says, acellular. It's human tissue for the most part. There are some that are porcine. And it's got a certain thickness to it that really has allowed us to create more and more natural reconstructions. And it's the acellular dermal matrix that has allowed for the prepectoral reconstruction because it kind of reinforces the skin. If you only have skin between your implant and the air, there's going to be sometimes that might fail because it's just not thick enough. Or there's, again, radiation or scars or various things going on. Whereas with the ADM, that's what the acellular dermal matrix is abbreviated, you are wrapping that implant in this extra thickness or extra cushion. One of my plastic surgeons used to call it an internal bra because he thought that was easy for the patient. And it really has revolutionized the reconstruction. Now, sometimes the patients can see, for instance, the edge of the implant or a little bit of rippling. I personally think that's a good trade-off for not disrupting the pectoralis muscle.
So in both of your opinions, you've got somebody who has expanders in place. We have been told or telling our trainers, no chest exercise while the expanders are in place. That means no push-ups, no flies, and it also means no rows because you're still doing an eccentric contraction. Do you agree, disagree, somewhere in the middle? I mean, I'm always on the safer side than willing to take any risks.
Yeah, I mean, first of all, they should check with the plastic surgeon who's been doing reconstruction. That's rule number one. Rule number two is let's use some common sense. Rule number three is you're looking at 6 to 8 weeks on up to 12 weeks to really have some really decent healing. That doesn't mean there can't be other upper body things to be done.
Exactly.
It does not mean that the last thing you want to do is to have a stiff shoulder come out of all this because you haven't done anything to keep the rotator cuff loose and whatever. Shawna, those would be my thoughts. What about yours?
Well, I agree. And I'm going to say I'm somewhere in the middle because most patients who have expanders in, I would say, find them uncomfortable because they're a little stiffer. They're a little more rigid than an implant is. But there's nothing inherently different about them as far as the musculature goes. It does depend a lot on whether you have a retropectoral or a prepectoral implant in. You certainly don't want to do anything while drains are in, and you want a pocket to form and all of those things. And sometimes women have a delay in getting their implant exchange done for a variety of reasons. They may need chemotherapy. They may be getting radiation therapy, or they may have coronavirus, who knows?
Right.
So I'm with Jay. I don't want them just to be totally socked in.
No, of course.
I think you can move without doing weight training. And so that's why I say I'm a little bit in the middle.
Yeah, and as am I. It's about doing the appropriate exercises and avoiding anything that's going to disrupt, dislodge, interfere with the healing. And then once the implants are placed, what I tell people is you're kind of starting all over, because then you've got the healing time from that as well. So I tell everybody that they need to get a medical clearance with each and every new procedure, because the circumstances change. And then our focus is on working on range of motion with no resistance. And then getting full range of motion back first. So it's definitely about movement. But if somebody's only doing this, then they become really strong just doing this, and then they never work to get full range of motion back.
Absolutely.
Yeah. I will say, I was thinking as I was preparing for this today, I had a patient one time who had implants in, and she really felt like she was kind of hunched over and tight. And she started doing Pilates, and she said it was the best thing she ever did, because even though she wasn't doing it vigorously or rigorously, she was slowly opening up and getting that range of motion. And I tell people that all the time, you can't get hunched over and just frozen.
No, and a lot of people are like that to begin with, and this just exacerbates it. And we have people who are yoga instructors, Pilates instructors, physical and occupational therapists, the whole gambit. And basically they take whatever their modalities are, because somebody who's not a Pilates instructor isn't going to be able to safely teach someone to do Pilates and so on and so forth, even with yoga. Jay, did you have something to say?
No, I don't. Shawna's made all the important points. There's one little caveat that we've actually, one of the plastic surgeons that I work with has actually done over 200, well, almost 200 prepectoral reconstructions without ADM. It's because you have to have tabs, and it's a two-stage approach with an expander first, while you get the capsule form around and then come back and straight out to the implant. So, but that's just a tiny little caveat. Work with the plastic surgeons that you're dealing with. And Shawna's point about the plotting, just even getting patients to stand up straight.
I know, I'm like this, I keep wiggling around.
Yeah, and just bring their shoulders together, just even that little bit of motion.
I tell people BCD. So back is an isometric back retraction. Chicken is bringing the head back in alignment, and D is door stretch. So that's like the homework I give everybody, and it's something they can relate to. There's something else I was going to ask you about implants. How often, if ever, do you find them ruptured?
With the modern implants, virtually never.
Okay. I mean, we tell people to be aware, don't do too much, don't put too much pressure, try and, if it's uncomfortable, not use prone position. But I've also stated that it's usually rare, but just to be aware of it. All right, let's move on.
If I could just say, especially in this day and age, I would encourage people, and this may not be in the realm of exercise, but in the realm of breast health, I would encourage people to know what kind of implants they have.
Right.
Yes.
Know whether they have silicone, know whether they have saline, know whether they have smooth, know whether they have textured, because that has become important over time. And it does help to answer that question, can they rupture? Because as Jay said, with the modern implants that we have now, they don't rupture in the sense of that word. Right.
Okay. No, good to know. I mean, these are questions that everybody asks me, and I answer them pretty much the same way, but I want them to hear it from you. So moving on to our other options, let's talk about Tram Flap versus Diep, SIEP. Everybody says, why on earth would anyone do a Tram Flap versus doing a free flap? And I'm curious what both of your opinions are on that. You know, I have my own, and they're more just personal experience. But why do your patients choose one, or do they? Do you tell them, no, you need to do this?
Shawna, go ahead.
Well, part of it is availability of microvascular surgeons, because I have been in the very fortunate position that I have had the ability, or I've had access to multiple microvascular surgeons for about 15 to 20 years. Mm-hmm. If you don't have a microvascular surgeon available, a Tram Flap is a very good operation if you want to have your own tissue. Mm-hmm. There are some drawbacks to it. It can weaken your abdominal musculature, especially if you're doing a bilateral. And there is a little bit higher incidence of fat necrosis, which is a situation where the fat cells don't have quite enough blood supply, and so you can get some firmness and some tenderness in some situations. But it's a very good operation. Some of the most beautiful reconstructions I've ever seen are Tram Flaps. So I wouldn't naysay about Tram Flaps, but I think if you have access to a microvascular surgeon, a Diep flap is better because of you don't have the fat necrosis, and you don't lose muscle in your abdominal wall.
Right. And then I was reading recently that the SIEP, I don't know if there's a SIEP flap versus the Diep, that they don't know if they can do it till they actually go in the operating room. And I don't know what the prerequisites are to do one or the other, or what the advantages are. Do you have any information on that?
Shawna?
Well, I would say they never know for sure whether they're going to be able to do any of these. Okay. I mean, there are some preoperative measures that some plastic surgeons use to get a CT scan to see what the vasculature is. I previously had some type of abdominal surgery. The plastic surgeons may want to do a vascular study just to see if they can see what the vessels look like. Okay. There's also something called supercharging vessels, where you can tie off one vessel to try and encourage another vessel to get bigger or to balloon up just a little bit. But the fact of the matter is, you never really know until you get in there whether you're going to have a good artery to hook into and a good vein to drain the flap, because part of the reason when flaps fail is because it doesn't have a good blood supply or a good inflow. And part of the reason they fail is because they get congested because they don't have enough outflow. And so you need both of those before you can for sure say it's going to work. And you don't always know that until you're actually looking at the vessels and the caliber of the vessels, the size of them.
Well, and I absolutely agree with all that. And you really need to be working with an experienced team of people.
Yeah. Oh, of course.
You know, I think, especially in microvascular, they have got to be really experienced. It is a big procedure, and as Shawna said, the donor vessels, if you will, are just critical, and access to them, and it's a highly specialized approach, highly specialized.
And do you find that more often than not, do you think insurance poo-poos it because it's a 9 to 12 hour procedure versus the 3 to 6 hour procedure, and it's going to cost them more money? Does that ever?
No, I'll have Shawna comment. One of the reasons we have less and less tissue being moved is because of decreased reimbursement for the hours that people are putting in here. Mm-hmm. And in my view, it's frankly criminal because patients should have that option if they want their own autologous tissue. Right. And the poor reimbursement, that's why I said it takes a team that can handle the poor reimbursement and get the job done. Shawna, do you agree?
Yeah, I totally agree with that. And I mean, I've not seen insurance deny or specify a specific type of reconstruction. I always counsel patients when they're trying to decide what type of reconstruction. Of course, you have to have enough tissue. I always joke with the patients, you know, in our world, you can be too thin.
Yeah.
Maybe not too rich, but
Oh, my mom had to gain weight when she had her abdominal tram.
Yeah. So, so that's one thing. But another thing is, I always say you're making a big commitment up front. I mean, it's a big hit right now, but it pays off for the rest of your life.
Mm-hmm.
And for insurance companies who are having decreasing reimbursements, yes, this operation is a long operation and it does require generally a 3-hour or a 3-day hospital stay, but they're saving the patient potentially more procedures in the future. Right. For instance, they aren't going to have an expander exchanged to a permanent implant. They aren't going to have permanent implants exchanged at some point in the future. Right. I find that patients are very happy with their autologous reconstruction for very much longer than patients who have had implants in. And implants are good. Don't get me wrong, yeah. But they're and sometimes they're a good stopgap because you need to get your surgery, you need to get your reconstruction, you need to get on with other therapy. Then you could have autologous reconstruction at a later date. There's lots of options. All about that personalized medicine.
Yeah, well, that's absolutely right. The expander can actually be used as a placeholder. Mm-hmm. Keeps the skin envelope expanded. All sorts of other things can go on and then come, whether it's several months later or whatever.
Okay, so it can be left in for long periods of time?
Oh, sure, absolutely. And then it's a beautiful placeholder. Mm-hmm. And then down the road and do autologous tissue. So,
okay.
That's where the team is so important.
Right.
Here because
but as doctors, do you ever assess, so one of the things that happened, my mom has had issues with bulging discs and what have you, and she had an abdominal tram. And I personally feel that was not the best choice for her. She wasn't fat or fatty. She didn't have, a reason to have a tummy tuck. I don't know what went into the decision making of that, or why somebody who has shoulder issues would have a lat flap versus something else. Do the surgeons consider that when they're making these choices? I mean, do they even know?
Well, they should know. But sometimes patients don't tell us everything.
Correct. Right.
Because they don't understand that this impacts everything.
Yeah.
I mean, I will have patients say, well, I have a frozen shoulder and, it's on the side of their cancer. And I'm like, oh, we got to get this taken care of before we really even operate on you. Yeah. We need to have this assessed. So it is about communication. And this really, again, is that personalized medicine, that individual decision-making. But I would say that back problems are not always focused on as a contraindication or even a consideration for whether you're going to have abdominal surgery.
And so, and these are all the things I discuss with everybody and all the questions to ask. And obviously, if somebody gets through one of these procedures and they're functioning perfectly, fantastic. But we're not going to know that until we do these certain assessments that we do, from a postural assessment to a movement screen to, range of motion measurements. And that's where I think one of the biggest concerns is the people who are working with cancer patients, in the gym and studios that don't have any specific training, that, they're doing the best they can, which is commendable, but it's not enough. And we're just talking about breast cancer. We're not even talking about treatments. We're not talking about comorbidities. We're not talking about acute and chronic side effects, and how important it is to understand all of this. I mean, I saw a physical therapist have somebody who recently had a mastectomy. I don't know the exact story, but he was having her do an Olympic bar chest press. And I mean, it doesn't matter just because you're a PT or an OT or even a doctor. That doesn't mean you understand it. So, Jay's seen all of the material, and Shawna, we're redoing everything so you guys will get to see and give your input. And I think it's really important that anybody who wants to go down this road be the best that they can possibly be, and not balk at having to retest every 2 years, having to learn more information, because it's constantly changing.
Can I ask you a question?
Sure.
So and I haven't read all your materials yet because I'm new to the fold. But what do you recommend as far as a preoperative assessment?
If possible, because I know the timing doesn't always work, but one of the things I recommend as becoming that next step in the healthcare continuum is offering to work in a doctor's office, surgeon's office, pro bono for a certain number of hours where we can do the assessments. And I think that the postural assessment is hands down irreplaceable. You cannot do without that. And I think particularly with breast cancer or any head and neck cancer, that shoulder range of motion should be evaluated so that we have something that we can compare to, one, for studies, but more importantly, you know, in the here and now is if somebody's range of motion was 130 degrees prior to surgery, then realistically that may be their norm, regardless of whether the standards say it should be 150 to 180. But the postural assessment allows us to look at people from front, back, and sides and identify any imbalances throughout the kinetic chain. And if there's anything out of place, you know, starting with the head being forward, that puts strain on the entire body, exacerbate that with scar tissue, with ischemia, with adhesions, guarding, all of those things. If we don't address that and we don't work on corrective exercises, then that person will always be like this because their central nervous system is going to adapt that as the new norm. So if I were to bring somebody into my clinic, my office, I would say we could do a quick half-hour postural assessment, goniometric measurements, and a squat test is another really valuable one, along with or instead of a modified Thomas test, which allows us to look at lower body biomechanics and movement patterns. All of this has to be addressed because you can send somebody to a trainer to work with, you know, increasing range of motion or stretching the chest, strengthening the back, and that's great. But we look at people as an entire being, not just the part that they had surgery or cancer. And we're working to correct all of these imbalances to decrease the amount of pain they're in or prevent future joint degeneration. So that might have been too big of an answer, but
no,
you know.
I don't think that's done often enough. And I'm going to use the analogy. Jay and I teach courses all the time to other surgeons. And one of the things we preach is that you need a baseline photo of how somebody looks. And if you don't do that, you don't really know how good your outcome was or how bad your outcome was.
Absolutely.
So
And
this assessment pre-operatively to me seems like that I do try to get patients to go see physical therapists before surgery. Mm-hmm. But as you've pointed out, there's so many things we ask patients to do. I mean, they're going to see genetic counselors and plastic surgeons and, you know.
It's easier if they can just do it. You know, you meet with them, send them down the hall. I mean, like Stacy, you know, maybe she'd be interested in doing that there. I mean, Jay, we have a ton of people in California. Believe me, if you guys yourself or you have colleagues that are interested in doing this, I can provide you with a list of trained professionals, cancer exercise specialists that I'm sure would jump at the opportunity and would also love to just, you know, have a doctor that they could kind of mentor, you know, be mentored by or follow. So these are people, the people who go through this very difficult course are really passionate about doing this. They really want to help. Most of them have personal stories. Most of the people who take this course are not your beginner trainers. They're not focused on bodybuilding and all that. This is people who really want to make a difference, you know, a career difference. So I would love to speak further with you all about that and see if we can't even get some trials going, not real trials because I'm not capable of doing that, but just amongst ourselves to see what the improvement could be or what the difference is from before and after surgery. And to be honest, you're going to end up with patients that they can be more fit than they ever were before. They can reach new heights because they may have been doing things improperly to begin with. Mm-hmm. That led to either, you know, their illness or orthopedic issues. And so we can correct all that and they get to be the brand new version.
And how empowering would that be?
It's pretty dang empowering for sure. And that's why I think
you know, let me jump in for a second. This is precisely, this kind of preoperative assessment is precisely why we're trying to get that included now as a part of NAPBC, National Accreditation Program for Breast Centers standard. Just measuring basic things at the beginning and then using that as a benchmark down the road, et cetera. Andrea, I see we're getting a bunch of questions coming
Yeah,
up.
I was going to hop on that because I know we're getting to the end of the hour. And I wanted to add, Shawna, also lymph measurements.
Yes.
Or
Well,
baseline.
and there's lots of programs now to do preoperative bioimpedance or measurements. But I'm feeling this. I'm seeing this light bulb go off in my head about a half an hour assessment. If we have this Life with Cancer program that is free to patients, and it may be something that we can look into. So we'll talk about that.
Are you familiar with Too Unstoppable in Northern Virginia?
I have heard of it, but I don't.
I'll have to put you in touch with them. They're great. And they're also doing free things and programming started by 2 lovely breast cancer patients, survivors. I'll introduce you. So to read the comments here, we've got Denise OT. Is this Denise Stewart? I'm hoping that it is. She says, agrees there needs. Okay, so Denise, she does our scar tissue and adhesions video. She is an OT in, I believe, Brisbane. And she does a lot of research herself and has her own programming. She's another person to introduce you guys to. So she agrees, realigning people to create the best version of them ever. I don't know if you two can see these questions, given the internal bra that Shawna.
I can. If you click on chat, I can see them. So.
Yeah. Do you want to answer that one, Shawna? It's the last one, I believe.
Oh, the internal bra. Yeah. So the recommendations for wearing an external bra. I'm going to say there's lots of urban legends about bras, and underwear bras do not cause breast cancer. Neither does deodorant, by the way. But support is good. I mean, support is good for most women. It's more comfortable to wear a bra than not to wear one. Especially the larger breasted you are. There are no muscles in the bra, so there's no amount of exercise that you can do that's going to make your breasts less droopy or ptotic, as we say. But that being said, you can over time lose some of the supporting structures or stretch out some of the supporting structures. So I think bras are reasonable to consider wearing, not mandatory, and there's not one bra versus another that has ever been shown to be better or worse.
Right, and then during the perioperative time, Andy, I would recommend a sports bra that zips up in the front, that's easier to get in and out. I think that's really important. Okay,
so
yay, agree on the underwear.
And we agree on exercise. So Shawna, we'll get you the new materials. I'm working, the book's being edited. We just did new videos, new pictures, everything. And I don't know if the stats are out yet for 2019. I haven't been able to find them, but if you all come across the stats of, number of cancer incidences, usually it's through Globacon. I would love to get my hands on that as well. And one last thing, have you done any Tdap or tug flaps yet?
I have not, no.
A few. They're not my favorite.
Yeah. Once again, I don't know why somebody would choose one over the other. And, and I tell the students, I'm like, there are personal reasons for everything. And by the time the client who was your patient gets to us, we're not making those decisions. We're just getting whatever we get.
Right.
We're not part of the decision-making process. We don't have to agree or disagree. We just go, okay, here's what we got. Now we're going to assess all of this and come up with the safest, most effective program to, like I said, get them back not only where they were before, but even better in many instances, because so many people were sedentary. Mm-hmm. So I really appreciate you taking the time out of your, Shawna, it's later for you. Jay and I are a little early. But thank you for taking time out of your busy day, and look forward to having you both as part of the advisory board. Yeah.
There's one more question. Option to observe a breast surgery. I don't know who that came from. There can be observers in the operating room. There's kind of an arduous process to go through. And you have to be, and if you're a healthcare worker, you've probably gone through almost all of it. But if there's a breast surgeon you're working with, they should be able to get you the paperwork and all of that to take you into the operating room.
Yeah, I did that with
that's beneficial for people working with breast cancer patients.
Yeah, when Ted Sangaris was at Georgetown, I got to sit in on one of the first sentinel node biopsies back. I think it had to be the late 90s. So that was Barb Pide. She is in Arizona. So I'm sure that, I think she's in kind of a medical setting. So that would be a good place for her to start.
Except they're probably not doing elective breast cancer cases right now because of the pandemic.
We haven't talked about the pandemic and we're at the end, but everyone's very concerned about the surge going on, particularly out here in the West, and whether that's going to impact us in the operating rooms, and it may. The other thing about observing breast surgery, you'd be amazed the number of breast surgical procedures on YouTube.
Oh yeah, yeah, I've put up links.
Keep looking them up. So
great place to watch a tram flap and lat flaps and all that.
Yeah.
So Andy, listen, it's been a pleasure being with you. This has been a lot of fun. Thank you.
I know, I've missed you. We haven't had our regular weekly talks, and look forward to catching up more.
And I haven't seen you in a while, Jay.
I know, and you look amazing. Like, I can't believe my son is now 20, almost 25, and I was pregnant with him when we started writing the book.
All right.
I know. All right, you guys. Thank you so
Good to
much.
see you.
Talk soon.
Take care. Bye-bye.
Bye.
Thanks. Bye-bye. Really appreciate it. Bye-bye.
Thanks, Jay.